So this first case is a 66-year-old woman who presents with locally advanced non-small cell lung carcinoma and is being evaluated prior to radiation therapy. So here is the whole body MIP image from her PET-CT scan, and you can see that there's focal activity in the chest, and then, as we'll talk about in a minute, some focal activity below the diaphragm. So on this image, we can see here's the primary lung carcinoma, and with PET-CT, we can nicely see that this is invading into the chest wall. If you go forward one. We found that PET is actually quite helpful in some of these cases where the anatomic differentiation, it's difficult to see whether this is merely abutting the chest wall or perhaps extending beyond the chest wall. But in this case, we can see the metabolism clearly extends through the chest wall into the subpectoral space. But I'll call your attention to this second site of activity below the diaphragm. And a couple of axial images here. So that brings us to our first question. So which of the following is the most likely etiology of this patient's colonic activity? Is it physiologic activity in the bowel wall? Is this a tubulovillous adenoma? Is this colon carcinoma? Or is this metastatic disease from lung carcinoma? Good, so almost everyone got this one correct. So the answer is indeed tubulovillous adenoma. And this was somewhat surprising to us as we started to see these sites of focal colonic activity on PET scanning. Sometimes they're quite intense, and at first we thought they were going to turn out to be just overt colon carcinomas. But clearly reports in the literature indicate that these are indeed adenomatous polyps of the colon more frequently than they are colon carcinoma. This is a diagnostic CT in this same patient that was read as normal in the abdomen, but in retrospect we can see that there is quite a large polypoid interluminal filling defect in the transverse colon. CT scanning is not very good at detecting colonic wall lesions because of the interluminal debris and things like that we're just not very good about seeing these lesions inside the colon. This is the patient when they went to colonoscopy. We can see this large pedunculated intraluminal polypoid mass, and on biopsy this did indeed turn out to be a tubulovillous adenoma. Now, of course, when these adenomatous polyps get to be this size, there's a finite and significant frequency of concomitant malignancy. So we actually screen for these with colonoscopy to prevent the development of colon carcinoma. And so this patient actually did go to surgical resection, and indeed at the time of surgery they found a very small focus of moderately differentiated adenocarcinoma within this polyp. But the point being is that the majority of this lesion, which we saw very clearly on PET scanning with an SUV in the range of 10 to 12, was almost entirely tubulovillous adenoma with only a very small focus of malignancy within it. So focal activity in the colon on PET-CT detected incidentally oftentimes does turn out to be a large adenomatous polyp. Contrasting with a couple of additional cases, here's a patient with lymphoma who presents with focal hypermetabolism in the right lower quadrant. We can see that this corresponds to circumferential mural thickening of the terminal ileum with stranding in the adjacent fat. And in this case, when endoscopy was performed, this turned out to be terminal ileitis related to Yersinia infection. Another example of diffuse colonic activity in this case with diffuse colonic wall thickening on CT scanning in a patient who turned out to have diffuse colitis, infectious colitis. So many different etiologies of colon activity, but that focal nodular activity does oftentimes turn out to be adenomatous colonic polyp. When do we recommend colonoscopy?
Is because of the size, and they didn't feel like they had to resect that lesion based on endoscopy. So they did a biopsy at the time of colonoscopy, but then preferred to go in and do a segmental resection because it was large enough that they didn't feel like they could safely resect it with a colonoscope. Case number 2 is a 61-year-old woman who's asymptomatic, presents with newly diagnosed non-small cell lung carcinoma, and a PET-CT is obtained for initial staging. I'll let you look at her image here. So we can see obviously the large malignancy in the left upper lobe with some ipsilateral nodal metastatic disease. But we also see diffuse activity
in the right forearm. And show you this on axial as well. So the next response question is, the uptake in the patient's right forearm is most likely due to which of the following? Is this cellulitis, cutaneous T-cell lymphoma, metastatic disease, or artifact? So most people picked cellulitis, which would be a possibility, although cellulitis should be more superficial. We come back to this presentation. The answer is that this is actually an artifact, but not an artifact of imaging. It's an artifact related to the injection. Now, I'll qualify by saying that this was not a scan performed at MD Anderson Cancer Center. This was a scan performed before I arrived at MD Anderson in my private practice in Florida. This is an intra-arterial injection of FDG. So recall that with all radiotracers, the localization method is based on several factors. We tend to think about the specific localization. In the case of FDG, we're thinking about localization and uptake by glucose transporter receptors as a marker of metabolism. There is nonspecific tracer activity. Some of our tracers merely go to areas of nonspecific adsorption, but recall that all radiotracers also have a component of flow. That as flow to a certain compartment increases, you'll also relatively increase the radiotracer localization regardless of the first two factors. And so what happens is when you inject a radiotracer intra-arterially, you have very high perfusion to that compartment and very high first-pass extraction of FDG from the vascular compartment. So the tissues, although they're normal and show normal glucose transporter expression, are being subjected to a much higher density and concentration of FDG than they normally would. And so you see relatively increased uptake in the soft tissues. This bone scan illustrates the same finding with MDP. So I talked to the technologist and said, I saw the images and said, did you notice anything funny about the injection? He said, well, I noticed that the vein was pulsating a little bit when I injected it, but otherwise it seemed to be normal. The patient fortunately was still there. I rushed in to take a look. You know, you want to make sure they're not developing a pseudoaneurysm or hematoma or anything like that. We had used a very small butterfly catheter and stuck it in and pulled it out, and there was no complication. But it is imperative to investigate and examine these patients to make sure there's no vascular compromise, because puncturing the artery with, say, a 18 gauge needle can result in a vascular leak and pseudoaneurysm formation. So again, this is nonspecific activity related to intraarterial injection. This next case is a 62-year-old man who presents with an enlarging left neck mass. A needle biopsy was performed, naturally enough, that showed scant fibrous tissue but no evidence of malignancy. So they referred him for a PET CT scan. Here's what his images look like. This is our head and neck protocol where we do the body first, followed by the delayed images from the vertex down to the aortic arch. On axial imaging, we can see this large mass, fairly homogeneous in appearance, deep to the sternocleidomastoid muscle at the level of the left mandibular angle. And as you can see, it's very intensely hypermetabolic on PET. Now, there are a few other interesting findings in this patient. Here's the sagittal and coronal imaging showing that this is somewhat fusiform in appearance. As we look through the body, we also saw several other interesting abnormalities in the left supraclavicular region, in the left prevascular space, and in the right gluteal region of the pelvis. You can see that there are these low-density soft tissue masses that show some FDG activity, but fairly low in intensity. So that brings us to our question, what is the most likely diagnosis in this case? Malignant schwannoma, Richter's transformation of chronic lymphocytic leukemia, Candida infection, or a normal variant? I can see the rate of responses up here, and I use that as an indicator to see how unsure people are. This is a difficult case, so as would be expected, we're a little bit across the board here. You know, we have the privilege at MD Anderson of seeing some very interesting and unusual scenarios, and one of the things that we see with some frequency are patients with neurofibromatosis, and they develop with a fairly high frequency malignant transformation of their neurofibromas that become malignant peripheral nerve sheath tumors or malignant schwannomas. So this is a patient who indeed has neurofibromatosis, and those areas of homogeneous soft tissue in the chest and in the pelvis with low activity represent the normal neurofibromas. What we see up in the neck is one of the neurofibromas that's undergone malignant degeneration and is now a malignant peripheral nerve sheath tumor, which is a variant of sarcoma. This patient had an ultrasound, which shows this homogeneous low echogenicity mass in the neck. Again, that initial biopsy just showed fibrous tissue, but excisional biopsy did confirm that this was a malignant peripheral nerve sheath tumor. Just a little bit of information about them. They account for about 10% of soft tissue sarcomas, so they're not a common tumor, but they're not exceedingly rare. About half of the malignant peripheral nerve sheath tumors arise in patients with neurofibromatosis type 1. When they occur in NF1, the peak is at around 25 to 30 years. Spontaneous malignant peripheral nerve sheath tumors without NF1, they peak about 40 to 60 years of age. There are some data in the literature that would suggest that PET is able to differentiate benign from malignant peripheral nerve sheath tumors, and this is the main indication why we do PET scan in these patients. They're referred to MD Anderson with a known diagnosis of neurofibromatosis. They have neurofibromas all over their body, paraspinal, they may be peripheral, some of them may be painful, some of them may be growing, but the question is, have any of these truly undergone malignant transformation, at which time you would need to do surgery and potentially treat with either chemotherapy or radiation therapy? And the literature would say that PET is able to differentiate benign from malignant tumors with a sensitivity of 89% and a specificity of 95%. And there is some suggestion that this may correlate with tumor grade. Next case is a 35-year-old woman with a history of colon carcinoma that's been surgically resected, has a rising CEA, and now has a biopsy-proven tumor recurrence in the upper abdomen. Here's her PET image. And I'll call attention to the two foci of very intense activity in the upper abdomen, as well as some less intense foci of activity down in the pelvis. So here's a diagnostic CT scan, which was read as normal, but subsequently she underwent PET CT, and we can see these very intense foci of activity along the bowel serosa and infiltrating along the vessels. And so if you actually can see, I don't think I have the laser pointer up here, but if you see on that diagnostic CT scan on the bottom, you can actually appreciate that soft tissue infiltrating along the mesenteric arcade, representing the site of recurrent tumor as well as disease along the serosa, which even in retrospect I can't see on the CT scan. Oh, very good, thank you. Let's take a look at the activity down in the pelvis. So we see two foci of activity here. One here and one here. And we can see those localized along the pelvic sidewalls. And some additional interesting activity located centrally here in the midst of this structure. And I'll show you side by side an image from the PET CT scan and an image from the diagnostic CT scan. So the question in this case is, what is the etiology of the findings in the pelvis? Are these Krukenberg tumors? Is this a Mullerian duct abnormality? Is this invasive endometrial carcinoma or an incidental ovarian carcinoma? Yep. Oh, I need to go back one. This is number 4. Okay, we can go ahead and start voting on that one, sorry. Good, so a lot of people are thinking about metastatic disease, and that would certainly be a possibility. The answer is actually Mullerian duct abnormality. So let's take a closer look at this case. What we see is activity in the endometrium and some activity in the bilateral ovaries. And this is a younger patient, recall, 35 years old, and the CT shows what looks like 2 endometrial cavities. And we see that same finding on PET, where instead of a single focus of activity in the endometrium, we actually see 2 endometrial cavities in this patient's uterus. The fundus is preserved. We don't see any indentation. The outer contour of the uterus is normal. And so recalling our Mullerian duct abnormalities, this would fall down in this category here, where we have 2 separate endometrial cavities with preservation. So this is either a partial or a complete septate uterus, and in fact on CT it looks like that goes fairly far down, and MRI would better differentiate exactly how far down that septum goes. So this is actually a fairly common conundrum on PET scanning, is what to do with ovarian activity in particular, because we know that certain tumors have a propensity to metastasize to the ovaries. So the question becomes, at what point do you say that that activity is perhaps suspicious versus which point you let that activity go as physiologic? So this algorithm kind of illustrates my personal approach to ovarian activity, and it tends to work out pretty well. First question I always ask is the patient premenopausal or postmenopausal? Because that really is the critical juncture. If the patient is premenopausal, and this is a tumor type that has a fairly low likelihood of involving the ovaries, say lymphoma or melanoma, something like that, then I would merely observe those patients. Now, we do have the privilege at MD Anderson that many of our patients do come back on a fairly regular basis, and so we're not so concerned about them disappearing and never being seen again. We know that we will see that patient again in 3 months, 6 months, at some point in the future, so we can put them on an observation and merely see what that activity looks like. If the patient is postmenopausal, and this may be related to the patient's age, but it's also possible the patients can be postmenopausal on a chemical basis. And I learned this lesson the hard way from a young patient who had ovarian activity that I at first thought was physiologic, but the clinician called me back and said, I'm hormonally suppressing this patient, so she should not be having any ovulatory cycles. She should be, essentially amenorrheic at this point, in which case she flipped over, even though she was only 20-something years old, into the postmenopausal side of this algorithm. In those cases, focal ovarian activity should not be a normal finding, and that should be pursued in some fashion. I believe that ultrasound or MRI are both reasonable ways of evaluating the ovarian structures. If that is normal, it's okay to put them back into the observation track. But if it's abnormal, then a biopsy would be indicated in order to determine whether indeed that represents metastatic disease. Now, this is in cases where that would make a difference in patient management. There's always going to be an intermediate category, somebody who is on the younger side of things, but perhaps has a type of tumor that would have a propensity to go to the ovary, like a history of ovarian metastatic disease, rising tumor markers with no other explanation, colon and gastric carcinoma. It may be reasonable in those scenarios, even if the patient is on the younger side of things, to go ahead and pursue that with anatomical imaging in order to make sure that there's nothing going on in the ovary. But this is a very common incidental finding in premenopausal women. It can be bilateral, it can be unilateral. Sometimes it can be quite intense. I've seen physiologic ovarian activity to have SUVs in the range of 8, 10, 12. So the intensity does not bother me too much. And like I said, if there's a chance that that's physiologic, my first inclination is to let it go as physiologic activity and put them on an observation track with follow-up at some point in the future. I'll use this just as a separate case example. This is not a case quiz, but this was a 53-year-old woman who has breast carcinoma, bone metastatic disease, has undergone chemotherapy and autologous stem cell transplant. She's also had palliative samarium-153 therapy for bone metastatic disease, undergoes PET-CT scanning, and we can see that she also has very focal activity in the left side of the pelvis, localizing to this structure along the pelvic sidewall. Now, in her case, She's older, she's postmenopausal, she's undergone a lot of therapy, she has certainly a high pretest likelihood of having metastatic disease, and indeed when we pursued her with an ultrasound, we saw normal ovary here with some follicles, but also a hypoechoic mass sitting on the ovary at the site where we saw the focal hypermetabolism. And this was pursued and did turn out to be metastatic disease. The caveat in this case is that when they went in with laparoscopy, they actually detected metastatic disease in both ovaries. So metastatic disease to the ovaries is about half the time bilateral, even if on imaging we can only see it on one side. Next case is a 75-year-old man with chronic renal insufficiency, has an indeterminate pulmonary nodule in the left lower lobe found on chest x-ray and subsequently confirmed with CT scanning, and PET-CT was performed for nodule evaluation. This is an older case of mine, but one of my favorites. We can see many sites of activity in this patient, but none of them really look like they're in the lungs. And that was the diagnostic dilemma in this case. And so as I interrogated the patient's history, this was the pulmonary nodule that we were being asked to evaluate. A fairly weak finding on CT, kind of a poorly marginated pulmonary opacity. It looks to me more like a focus of scarring or atelectasis. And we can confirm on PET scanning that this shows very little activity, essentially equivalent to background. Nevertheless, and somewhat surprising, we saw numerous lytic and mixed blastic and lytic lesions in the skeleton that were quite intensely hypermetabolic. Expansile, lucent, one in the posterior column of the acetabulum on the left-hand side, one in the iliac bone, one in the anterior iliac bone on the right-hand side, and a couple of other lesions. Now, there was another interesting finding in this patient, and that was up near the thoracic inlet. Saw a fairly subtle focus of activity sitting here. And on PET-CT, we can see that it localizes to this area right along the tracheoesophageal groove on the left-hand side. And here's a CT scan on this patient that was done without intravenous contrast because of his renal insufficiency. And we can again see this abnormality sitting here along the lateral tracheal margin. So we'll go to the question in this case, what is the most likely diagnosis? Metastatic lung carcinoma, multiple myeloma, polyostotic fibrous dysplasia, or hyperparathyroidism? Good, so a couple people got the right answer. This is in my top 10 favorite cases of all time. This is actually hyperparathyroidism with multiple brown tumors. And this has actually been reported in the literature. So this patient with chronic renal insufficiency has a parathyroid adenoma that's ectopic along the left tracheoesophageal groove. And these lesions in the pelvis were actually biopsied because at the time we saw the lung lesion was negative, we saw extremely hot bone lesions. I get a call from the pathologist a few weeks later saying, you know, these look like brown tumors, is that possible? And like I said, there are a few reports in the literature of brown tumors being hypermetabolic on PET scanning. This is a very interesting article. It was published quite a while ago, 2001, in the journal Radiology, where they looked at the metabolism of both benign and malignant bone lesions. And we've subsequently expanded our knowledge across some of these spectrums. But what's interesting to see is that there are benign bone lesions here in the open circles and malignant lesions in the dark circles. And you can see that there's a fair bit of overlap. There are some classically benign bone lesions, such as Langerhans cell histiocytosis, which show a fair degree of metabolism on PET scanning. Sarcoidosis of bone, chondroblastoma, and giant cell tumor are all lesions which are very metabolically active on PET scanning. Contrasting that with some malignancies like chondrosarcoma, which can have fairly low activity. So demonstrating that there is a fair degree of overlap between benign and malignant bone lesions, and that some of these quote-unquote benign or less aggressive osseous lesions can indeed show activity on PET scanning, and brown tumors fall into that category. Parathyroid adenoma. Yep, that was the primary parathyroid adenoma that was driving all of these brown tumors in the skeleton. This next case is a 79-year-old man with squamous cell carcinoma of the scalp. He's undergone surgical resection and radiotherapy for that primary tumor, and FDG PET was obtained for subsequent treatment management. So here's his scan. I'll let you look at this for a minute. Again, we used our head and neck protocol for this case. So the question in this case is, which of the following, if present, is the most ominous finding in this patient? And maybe what we'll do, can we start the voting and then switch back so they can see the image? Because I want them to look at that while they vote. So the question is this muscle metastasis, lymph node metastasis, adrenal metastasis, or bone metastasis? Which is the worst finding? Obviously, this patient has multiple sites of metastatic disease. So let's go ahead and look at the answer in this case. And this is actually a fairly common pitfall with PET imaging, or a PET fall, if you will. And that is, we're relatively poor at seeing sites of disease that are occurring in sites where we normally see physiologic activity. So we tend to develop blind spots when we look at a PET scan with its regards to activity in and around the brain, activity in and around the urinary bladder, or activity in the heart. So this patient actually has a very large myocardial metastasis that on the planar images, on the MIP image, we go back a few, looks somewhat like physiologic cardiac activity. In retrospect, you can see there's a little bit of subtle nodularity. It's not quite conforming to the contour of the myocardium, but we tend to see that activity, and it just looks like normal cardiac activity. We can see in this case the patient also has a large pleural effusion as a result of that metastasis. So ventricular metastases are a rare site of metastatic disease, but about 50% of these occur in patients with carcinoma, and about 50% occur from metastatic sarcoma. They can result in many different adverse outcomes, but the most common of which are AV block, outflow obstruction, or ventricular rupture. And as you would expect, these generally have quite a poor prognosis. I'll just show you a couple of case examples. Here's a patient with a PET scan showing widespread metastatic disease, but including this focal activity sitting here in the anterior chest. And when we look at the PET CT image, we can see that this is localizing right along the interventricular septum. And on diagnostic CT scanning, we can see that the septum is quite thickened and nodular, corresponding exactly to where that activity was on PET scanning in this patient with metastatic anaplastic thyroid carcinoma. Another patient with multiple myeloma, we can see focal activity, in this case, localizing to the pulmonary outflow tract. Pretty convincing, pretty solid and focal and nodular. And when we followed this up with a diagnostic CT scan, we can see that there's an intraluminal mass sitting here, and this is actually further characterized with an MRI to be able to look more closely at the relationship of this mass to the valve and to the myocardium. But this did turn out to be metastatic melanoma to the right ventricular outflow tract. A final example, again, focal activity sitting here in the mid-cardiac region, interatrial septum, interventricular septum. Again, widespread metastatic disease. This was cutaneous squamous cell carcinoma with, again, metastatic disease to the interventricular septum. So although these are rare, I wouldn't say they're extremely rare, and these are things that do come up on occasion, and as I said, have a generally poor prognosis and some fairly bad adverse outcomes that can occur. I'm going to skip ahead a few just to get to some of the cases. Let's go to case number 9. And if folks want to come up afterwards, I'm glad to go through the rest of the cases and just do them as a show and tell. So case 9 is a 29-year-old female with a long history of knee swelling that's been occurring since age 6. She has recent worsening of the swelling with onset of progressive knee pain. An MRI was done that showed some joint fluid and some synovial thickening. Interestingly, you'll notice that the process in the articular space is low in signal on both T2 and on T1. And here's her PET scan, showing very prominent activity in and around the left knee. And on the axial images, we can see that this conforms very well to the extent of synovial thickening seen on MRI. And we can also see this on coronal imaging, really all throughout the articular space on the left-hand side. Sagittal images as well. So the question in this case, what is the most likely diagnosis? Is this juvenile rheumatoid arthritis, septic arthritis, pigmented villonodular synovitis, or synovial sarcoma? Sorry, we'll need to skip ahead to the appropriate case here. There it is. Yep. So JRA, septic arthritis, PVNS, or synovial sarcoma. Great. I'm very happy most people got the right answer in this case. Keep in mind that synovial sarcoma is actually not related to the synovium. It's a tumor that under histopathology has a structure somewhat reminiscent of the synovium. There's not a lot of literature related to synovial sarcoma. In our personal experience, we've seen those to be relatively low in intensity and oftentimes just occur in the soft tissues. They don't arise from the joint space itself. This was indeed a case of pigmented villonodular synovitis. I wanted to put this up because there's some very interesting developments taking place. This falls into one of these interesting categories of diseases that have long been considered a benign process, but as we move more into molecular pathology, we're understanding that there is indeed a component of neoplasia associated with these. So the broad generic term for these tumors is tenosynovial giant cell tumor. And there are two subtypes of this, pigmented villonodular synovitis and giant cell tumor of tendon sheath. But they're both essentially the same process, just occurring in different compartments. PVNS can be either focal or diffuse, and on histology, what we tend to see is a hemorrhagic effusion, hemosiderin-laden macrophages, and it has a classic appearance on MRI of being low signal on both T1 and T2. Most tumors would be low signal on T1 and high signal on T2, but because of this hemosiderin, it causes the signal on T2 to go down, giving it a very characteristic appearance of PVNS. On histopathology, there appear to be two components. And so what happens is if you do a synovectomy in these patients and you do a biopsy, what you'll get is a polyclonal population of reactive cells, macrophages, just a whole bunch of junk in the joint space. And so for a long time, this was presumed to be some sort of benign proliferative process of the synovium that would bleed. But as I said, when we get to the molecular pathology, what we find is there's a very rare underlying clonal neoplastic proliferative process. I liken this somewhat to Hodgkin's lymphoma, where there's a large tumor mass, and interspersed amongst that, we see the rare Reed-Sternberg cells that are actually driving the disease. PVNS is very much the same. There are rare tumor cells interspersed amongst this. The genetic event that's taking place is a translocation of the CSF1 gene, which makes colony-stimulating factor 1. So these tumor cells start overexpressing colony-stimulating factor. That recruits in a ton of macrophages, causes this histiocytic and macrophagic proliferative process in the joint space, being driven by these underlying tumor cells. And so this actually is now being thought of as a tumor of the joint space, rather than a benign case of chronic synovitis. And at MD Anderson, we are starting to treat these patients with targeted therapy like sunitinib and imatinib and some of the other small molecule therapies to try to treat this as a malignancy. As I said, there are other tumors that are falling under these lines, including things like Castleman's disease, Rosai-Dorfman, giant cell tumor. These are all things that it's looking like are going to turn out to be malignancies that have long been thought to be benign conditions. Still in all, the treatment of these is primarily surgical, but as I said, targeted therapy is used for recurrent or disseminated disease. Another case example, this was a patient with lymphoma that had been followed for a number of years, where we consistently saw this focal activity here sitting below the ischium on the right-hand side. And intermittently on some PET scans, we said that that was post-traumatic. Sometimes we said it was nonspecific. But eventually you start seeing this time and again and start to think maybe there's something else going on. You can see this on the coronal images, again, sitting adjacent to the ischium. The patient had here's the PET CT scan. The patient had an MRI study. This is actually a diagnostic CT scan, showing this mass sitting here. MRI scan in this case showing a low signal mass on T1. This is actually higher in signal on T2 sitting in this location. And this was biopsied, and this turned out to be giant cell tumor of tendon sheath. So they surgically resected it, and it appears to be a complete resection of the tumor in this particular patient. And I promised my colleague Dr. Fry I would show this case of a 60-year-old woman who had a long history of PVNS of the left knee, had had multiple prior synovectomies and therapies, and we can see this PET CT scan. She started presenting with areas of musculoskeletal pain. We can see the recurrent disease throughout the left knee joint. She's had a prior right knee replacement, and a lot of that activity on the right-hand side is probably just reactive or adjacent to the metal. But we can see recurrent synovial hypermetabolism in the left knee, and then these interesting areas of activity elsewhere in the body, including in the posterior chest wall, in the posterior pelvis. So we can see here in the presacral space, posterior chest wall, lateral chest wall. And these were eventually biopsied and proven to be metastasizing PVNS. So we see these rare cases of what would classically be considered a benign tumor, but now that we understand this underlying clonal population, we can understand that sometimes these can develop a component that can indeed become metastatic. So this is metastasizing PVNS. And I think I will stop there to maintain our time. And again, thank you everyone for attending, and thanks to the organizers for inviting me.